I'm Mike Royer with an extended interview in this Health Matters Web Extra. Welcome to this edition of Health Matters. We're joined once again by Dr. Pamela Payne-Foster, who's been on our program several times. It's always a pleasure to see you.
Always a pleasure.
Well, here's this experienced African-American physician being interviewed by a white guy in his 60s, and we're going to talk about racial disparity. And I'm glad you know a lot about it. I'm aware it happens, but I don't understand it. And in 2021, I want to go, that was a snap of my finger, and go, stop doing that. That's right. Let's make it all equal. That's a dream. But are we making progress in serving African Americans in this country medically better than we have in the past?
I would say better, still have a long way to go. I think even just recognizing that there are racial disparities, we even use the term inequities because we want people to think a little deeper than just black-white differences. When I say inequities, I want people to think about systems that make people different in this country. So inequities around history, context of history for African Americans in this country. We have to talk about slavery. Even though it was a long time ago, some of the remnants of it are still around to really talk about differences in health.
And you really would think that these days should be totally equal, but it still isn't. What are the barriers? What is causing young, middle-aged, and senior adult blacks to not get the exact same treatment I've gotten all of my life and continue to get? Give me I think you mentioned 6 specific issues. Just discuss that with us if you would.
We're still getting data and learning about this issue. This is something we are still studying. There's 6 diseases that we have studied that we know that there are disparities. And when I say disparities, inequities, I mean around either new cases, existing cases, morbidity around diseases, challenges around diseases, and mortality, deaths, and also even things like survivorship. Like, for example, cancer is one of those diseases where we see differences. Here in the U.S., we generally talk about underserved minorities, blacks, Latinos, Native Americans, and Asian Pacific Islanders. So we've seen differences between those groups and the majority white population. But cancer is one, cardiovascular disease, HIV/AIDS, diabetes, adult immunizations like flu vaccinations, and we're now talking about COVID vaccinations, and infant mortality. So those are the things we've studied, but we still have a long way to go.
And so important to medicine and treatment of medicine are studies, test studies, year-long, multi-year-long studies, and unfortunately, historically, blacks have not either participated, maybe by their choice, or just not been invited to participate in those. We can't know much about cancer in African American subjects if it's not been studied correctly.
But one of the things we do know is access is a major issue. If people aren't insured, socioeconomic status, things like that, if they can't get to the doctor transportation-wise, we know those are barriers. But one of the things we've learned, and we were talking about clinical trials, the physicians and providers get their information about how to treat from clinical trials. And if certain populations don't participate in clinical trials, then we don't have that information. So populations like blacks, like women, sometimes we've learned more about cardiovascular disease. You see I have on red today because this is Go Red Day for American Heart Association. A lot of people still don't think women have heart attacks, and cardiovascular disease is the #1 killer of women. So, and that's because traditionally women and minorities weren't in trials. Of course, we know historical events like the Tuskegee syphilis experiment, that distrust that came about because of that experiment. People are really hesitant to do clinical trials or get vaccinations, just distrust in general with science and with the medical establishment.
Those awful syphilis experiments done at Tuskegee, was that in the 40s?
It started in 1932, believe it or not, and ended in 1972. So 40 years that trial went on. It's the longest non-therapeutic clinical trial in history. That's why we often kind of think about it, because can you imagine?
Well, I think about it and think, wow, that was a long time ago.
Yes.
But if it was done on my people, it would still be very fresh in my mind that we couldn't trust them then. Can we trust them today? As an intelligent, well-educated physician, you believe we can trust the medical community today? CDC, other agencies?
I say examine closely. Even as an educated person, you know, we can talk about the COVID-19 vaccines. We know that, and I know that a lot of the resources would put into making that vaccine.
Yep.
We use technology, the mRNA technology
Yep.
that was already on the scene. There was already a lot of work being done for HIV vaccines, so that was just pivoted into the COVID-19. I trust that science.
Yes.
So even with the history I know of the Tuskegee syphilis and some of the distrust there, I trust what's in it. I always get my flu vaccine, and I just got my first dose of the COVID-19 vaccine. So, but I don't discount that people have distrust and have
No.
their reasons for not taking it. But we need to have conversations really about it. It's really important for us to think about the entire, as much of the population getting that COVID-19 vaccine, for us to get herd immunity in order for COVID-19 to go away and for us to get back to normal. But we've got to have conversations and really educate people on what the vaccine is, what it does, how it will help each individual getting it to get us to herd immunity, and et cetera. So it's a lot of work that we have to do, continue to do. Of course, we've talked about COVID-19 disproportionately affecting African Americans.
Yep.
So because of that, we've got to really push. I'm pushing for vaccine rollout in certain particular communities because I think it's important.
You work in the rural Black Belt. You
Mm-hmm.
you visit those areas. You treat people there. You talk to people there. Are you being supported in getting vaccine rolled out and available to them in those underserved areas?
That is a question mark, Mike. Not as fast as I would have liked. Of course, most of it is more centralized in urban settings, because it got rolled out to hospitals first and then to healthcare providers.
Yeah.
How they interpret how to get it out to the most needy communities is up to their interpretation. I was going to talk about provider bias being an issue, even in addition to access, because one of our seminal studies in health disparities was the Georgetown study. And what they did was they brought in actors, white males, white females, black males, black females. They had the same symptoms, and they asked the doctors, how would you treat these people, even though there were differences in race and gender? And because the physicians were mainly white male, they treated the blacks and the women less aggressively, gave them less aggressive treatment than the other.
Doesn't that make your head just want
So
to blow up?
What it does, because the headline said, "Is there sexism and racism in medicine?" Well, if you ask those doctors, they would probably say no.
Yeah.
It's really unconscious. It's really implicit. So we've talked a lot more in medicine about this implicit bias, this unconsciousness, and we've moved to this term called cultural competency. So we spend just as much time with our medical students, getting them medically prepared to treat patients, but they also have to be culturally competent to treat their patients in order to give them the best health outcomes they need. The other term we use is health humility, cultural humility. So we're taking it from the cultural competency to a cultural humility, sort of broadening the definition to say, as physicians, healthcare providers, we don't know everything. We can learn more. We can learn about different populations. I know we were having a conversation about just exposure to different groups. This is all a part of what we probably need to be thinking about when we talk about these racial disparities.
This university is training doctors who
Yes.
are going to be doctors someday.
Yes.
Are they being taught this, besides how to do surgery and how to treat this and how to do
Yes.
this? Are they being taught, if you finish this school, you're going to be more sensitive to every patient that comes to you?
I think it is being taught sparingly. I give those lectures, and some others give those lectures. We need more of it. We've talked about having more of it in medical education curriculums because it's so important.
Before we began talking, I said we could talk for a half hour.
Yes.
We've talked longer than normal, but let's continue talking about this.
Okay.
Let's keep educating everyone about that, and
Right.
especially our physicians. But none of these problems will be solved overnight, but we can't take forever either.
Yes. Thank you so much.
Thank you so much.